He will be giving a guest lecture before we start our IC. Dr. Dushyant Wariyapola has been a consultant ophthalmologist at Sri Jayawardene General Hospital, Sri Lanka for the last 24 years. He initiated phacoemulsification in 1996 and is an expert in complicated cataract surgeries. He was a pioneer in establishing treatment for ROP and modern techniques of lamellar keratoplasty in Sri Lanka. He is renowned for DALC, DSEC surgeries as well as refractive surgeries. His other special interests include glaucoma and medical retina. Dr. Wariyapola was the president of College of Ophthalmologists of Sri Lanka in 2006. He presided the SARC Academy of Ophthalmology Congress when it was held in Sri Lanka in 2014. He is a regional secretary representing Sri Lanka in Asia Pacific Academy of Ophthalmology. With these few words, I introduce to you Dr. Wariyapola, please.
Thank you very much for that kind introduction and inviting me for this talk on modified phaco-capsulotomy. Well, if you don't tackle a mature cataract properly, you might actually need to consider techniques that are going to be taught in a little while with implantation of IOLs without capsular support. I have no financial disclosures to make here. When a cataract matures, there is degeneration of lens proteins which creates an osmotic gradient, and there is entry of fluid into the lens fibers which result in hyperhydration of the lens fibers and cortical liquefaction. And there is increased intralenticular pressure which causes the periphery of the capsule to become very steep, and later on there is even nuclear liquefaction. Now, this was a separate new concept that Figueredo came out in 2012. He said that there is a nuclear block here which does not allow free flow of fluid from the posterior to the anterior compartment, and he called it the equatorial barrier. And this resulted in anterior and posterior two pressurized compartments. With time, of course, the nucleus also undergoes liquefaction and the nuclear block is relieved. Now, I am going to talk today about white, mature and intumescent cataracts where the nuclear block is still present, and rather than the hypermature and the Morgagnian cataract where this has been released. Well, there are two problems that are seen in dealing with mature cataract. One is the lack of red reflex, and the other is the Argentinian flag sign, or the extension of the rexis. Now, the first one, the lack of red reflex, is solved by staining with trypan blue. And one tip is that when you have a patient with a small pupil, start injecting under the iris so that the whole capsule is stained rather than just the center. And when you do that, when you stretch the pupil or dilate it with any other means, the whole capsule will be stained. Well, peripheral extension of the rexis was called the Argentinian flag sign by Peroni in 2000, and this was solely believed at that time to be due to increased intralenticular pressure. Well, the sudden release of liquefied cortex was thought to be the reason, and also the steepness of the periphery, which extended the rexis to the periphery. Now, but according to Figueredo's concept, the equatorial block creates two pressurized compartments, and as the capsule is opened here, as you see here, there is decompression of the anterior compartment. The fluid is released to the anterior chamber, and the unopposed pressure in the posterior compartment pushes the nucleus up, which hits against the partially opened anterior capsule, and this results in the capsular rupture or the Argentinian flag sign. Now, there are many ways that had been described to prevent a capsule rupture. Aspiration of liquefied cortex with a needle, high viscosity OVD to flatten the anterior capsule, You can use high viscosity OVD to flatten the anterior capsule as seen here, or massaging the anterior lens surface, which also redistributes the liquefied cortex in some people, where we use the intraoperative OCT to see what happens to the anterior lens surface with massaging. In some, it is moldable like this. And if you have a concavity like this, at the end of massaging, you can do the rhexis within this concavity, and you will not have a problem. But in others, it did not cause a concavity, and we were not able to alter the shape of the anterior lens surface at all. So the problem with all these techniques is that they only address the increased intralenticular pressure and not the posterior compartment pressure and the equatorial block, which are perhaps the more crucial reasons for the capsular rupture. Now, phaco-capsulotomy was described by Mahalingam and Sambhav in 2014. Here, the anterior capsule is punctured or opened directly with the phaco probe. This will aspirate the liquefied cortex and decompress the anterior compartment at the same time. As the capsule is opened, the decompression of the anterior compartment happens, and this technique too only reduces the intralenticular pressure in its traditional form. Now, I have modified the phaco-capsulotomy so that it addresses both problems associated with intumescent cataracts, increased intralenticular pressure and the pressurized compartment. Well, one thing is that what I do is I keep the sleeve well back, leave the tip opened a lot, so that it will prevent fluid inadvertently getting into the bag, which can actually increase the intralenticular pressure and cause a rupture. The other is that as you do the phaco-capsulotomy, as the decompression of the anterior compartment takes place, I push the nucleus down with the phaco tip without allowing the nucleus to come up. So you push it actively down, and this prevents the anterior, the migration of the lens, the nucleus, due to the unopposed action of the posterior compartment pressure. And when you press down, the fluid in the posterior compartment comes into the anterior compartment, and this reduces the posterior compartment pressure, and there won't be any tendency for that nucleus to come up. So here's a video. I stain with trypan blue, inject OVD, try massaging. Here you can see that it does not really alter the shape of the anterior lens surface. And again, do phaco-capsulotomy. As soon as I go in and then do the capsulotomy, you can notice me pressing down on the phaco probe, which prevents the nucleus coming up at all. And this kind of ballots the nucleus down and gets the fluid in the posterior compartment to come up. And then I do the capsulorhexis, and you can actually do a capsulorhexis which can be reasonably large, so that you don't have to enlarge it even further. So here you can actually, without any hesitation, do a reasonably large capsulorhexis. I don't do hydrodissection in these patients. And most of these patients, the nucleus is not that hard, and you can actually go through without any problem. And here is another video which shows that just as the capsule is open, the pressing down of the nucleus happens, and you prevent the nucleus coming up to prevent the Argentinian flag sign. This is another video which shows the same thing. Just make sure that as the capsule is open, press down on the nucleus. Well, are there any contraindications? Now, this patient who has had a TPPV, there was sudden increase in the anterior chamber, deepening of the anterior chamber when I introduced the phaco tip into the anterior chamber. So this phaco-capsulotomy caused a peripheral extension. Perhaps this is due to a reverse Argentinian flag sign which has recently been described. So in conclusion, this modified phaco-capsulotomy can solve both problems associated with white mature cataracts, the increased intralenticular pressure, as well as the unopposed action of the posterior compartment due to the nuclear block, and prevent an Argentinian flag sign. Thank you.
Thank you, sir. It was indeed an innovative technique. I would like to ask you, is there a learning curve to this technique?
Not really. I mean, it's a simple thing. You just open up the capsule with the phaco probe, which has been described by many. And only thing that I do is I just make sure that the tip is exposed a lot so that there is no fluid into the anterior chamber, into the bag at all. And a lot of people describe it as keep the tip bevel down. Now I don't do that, because when that happens, it catches sometimes it catches the capsule, and if the zonules are weak, you can actually pull the whole thing. So I don't do that. I don't hold the capsule. My intention is to reduce the intralenticular pressure as well as prevent this nucleus coming up. I feel that it is actually when you really think of it, I think it is the unopposed action of the posterior compartment pressure which really pushes the nucleus up, and that hits the capsule, and that is the reason for the capsular rupture. That's what I feel. So to prevent that, you push the nucleus down. It's quite a simple thing.
Yes, I'm sure.
Thank you, sir. But if I do 100 odd such intumescent with a high intralenticular pressure, how many times do we really succeed in all this? Are we 100% able to do with a high intralenticular?
Yeah, last 2 years I would say 100%, except that patient I did
post-vitrectomy.
Post-vitrectomy. So after that, I had one more post-vitrectomy. I didn't do that. I just did a milking massaging technique, and that was fine. So I guess in those patients, there is no risk of posterior compartment pressure. I should not have done that, but well, you learn from this. So I think it's not a difficult procedure, and
the phaco
virtually,
settings,
I mean, in my cases,
it's
the last couple of years, it has been 100%. Now, the thing is very difficult. Most of these actually don't extend. The ones that extend are the ones that you saw. I borrowed that from this thing where you keep a nick and it splits. Now, I want to prevent that happening. Now, a lot of people describe going across, doing the rexis. I think that you can easily prevent by using a very high viscosity OVD. But to prevent the ones that you get a rexis extension as you go in and touch, I think this is the only way that you can do.
Any particular phaco settings you would like to suggest for phaco puncture with this?
No, I mean, this is just sculpt mode settings. I just make sure that you aspirate the liquefied cortex, so it just comes out very easily. The more crucial thing is to go down and not to occlude the capsule nor the nucleus.
Thank you, sir.
Thank you.
That was an innovative technique.